abdomen, don't immediately make a judgment call that it's an infection. Because remember, a lot of people, when they have a runny nose, then they swallow it. Okay, I know that sounds really gross, but that's what most people do. Okay, so that's a false positive. The other thing, what else about indium? How come, what's the problem with imaging too soon after labeling the white blood cells and injecting them?
The lungs, you see the lungs?
Okay, yeah, for about the first 4 hours minimum, it's going to be in the lungs. So if there was a lung infection going on, which would be the best one to use? Technetium labeled white blood cells or indium labeled white blood cells? Indium. Okay, the tech, remember, if you have to wait more than 4 hours, okay, you're not going to have very much activity left in the lungs. So it's probably better to use indium to look at lung infection images. Okay, this one here, okay, I do want you to, did you guys try this out? If you have not tried these math problems, shame on you. Okay? So, when we're doing this, again, this is your standard. So now this is if you probably gave the patient a capsule and then you kept the capsule as a standard. Oh man, my eyes are terrible. I can't see the damn thing with or without my glasses. What do you do when that happens? Will you change my eyeballs? Get an eyeball transplant or something?
Puff it up.
Yeah, laser.
Laser is only good for 10 years.
Is that all? 10 years for
Yeah, that's what I said.
Okay, but again, on this one up here, remember that it's going to be the neck counts minus the thigh counts. Now, the other thing is decay factor of 24 hours. Okay? So, normally you count the capsule in the morning on the day that you give it to the patient. You have to decay it down 24 hours, so this is where your decay factor goes down here. You subtract background, and again, this is where they normally leave that plastic thyroid phantom, or that thyroid cylinder there when they do the count, except without the capsule in it. The important thing is making sure that you have the proper distance. I think most people use about 30 centimeters.
30.
Yeah. The main thing is that you have to have reproducible geometry. Okay, if it's too close, your count rate's going to be higher, which will make the uptake lower. Okay, and one of the nice things that they like to do to you on board exams is they'll ask you a question. If you have the uptake probe too close, you know, either the background or the neck counts will be different, and that can affect your uptake. Does that make sense? So you have to be able to rationalize that also. But again, so as far as the formula goes, you may want to write this down next to it. So the neck counts minus the thigh counts, and then the times 100 is to get the 100%, and then divided by the capsule counts minus background times the decay factor. So everyone okay on that? So about 48%. Did everyone get that when you guys tried the calculation? Did anybody have a problem with that? Okay. You definitely get questions like that all the time. Next one here. While performing a bone scan, you notice multiple locations of focal increase throughout the axial skeleton. Now remember, what is the axial skeleton? Yeah, okay, yeah, it's skull, spine, ribs, pelvis. Okay, so that's very consistent with metastatic disease. Okay, why is that?
There's like maybe better access to it. It's the core in the center.
Well, we haven't, you know, we're going to be starting oncology pretty soon. I'm going to be sending you some stuff tonight, some handouts and stuff like that. But basically, malignant tumors tend to invade surrounding tissue. And eventually they wind up getting into the bloodstream or into the lymphatic system. So if they get into the lymphatic system, then we see it in the nodes. So typically like the periaortic nodes, the cervical nodes, things like that. If it gets into the bloodstream, then it will go to the nutrient artery of usually the extremities, or and because there's normally only like one major blood vessel going into the bone, it tends to get trapped in that first capillary bed. So that's why you see metastasis that. Next one. Okay, this is a clinical procedures one. Again, you should know the pattern for both normal heart perfusion, ischemia, and infarct. Okay, so this one up here, so which one? Myocardial infarction. Okay, both abnormal. Abnormal rest, abnormal stress. Okay. What if you have abnormal stress and normal rest?
Ischemia.
Okay, ischemia. What if you have abnormal stress and normal rest?
Not possible.
Well, what can happen is you can actually infiltrate a dose. And so what will happen is you'll get kind of weird results. So that's why you have to be very careful about, if you get an infiltration, especially with thallium.
Abnormal stress and the normal rest, you said?
Yeah, but whichever you do first, because what will happen is the other stuff eventually will start getting reabsorbed through the muscle. And so when you do a delayed picture, especially if you're doing thallium, because usually with thallium, they used to do it like you immediately do the stress, and you have the patient come back in a few hours for the rest. Okay, so if you infiltrated the dose, you're going to get some very unusual counts. And that's why, when I gave you that quality control of SPECT imaging of the heart, you check the counts. Especially if you're doing sestamibi, because whichever test you do first, if you're doing the stress first or the rest first, you typically give about 10 millicuries.
Yeah.
When you do the next part, or the second part, especially on the same day, you give 30 millicuries. So what you need to do is a composite. So when the computer reconstructs the heart, you measure the number of counts. You should have 3 times the count rate in whatever that second image is, if you didn't have an infiltration. That make sense? Okay. So on this one here, so make sure you remember the patterns for that. Okay. They don't usually give you that on. Okay. Now the next one, your occupational whole body dose limit. Remember that any of those are fair game. So 5 rem whole body, and then what is it to the lens of the eye?
15.
Okay, and then what is it to everything else?
50.
50 rem, okay. And that includes both internal and external doses. Okay. What do we call that, by the way? The combined external and internal dose? Yeah, TEDE, total effective dose equivalent. And that's equal to the DDE, which is
Deep dose equivalent.
deep dose equivalent, and the CEDE.
Committed effective.
CEDE.
Committed effective dose equivalent.
Okay. All right. Okay. How many disintegrations will give you a count rate of 640 CPM when measured with a detector of 85%? Okay. So here it's very easy. Just 640 divided by 0.85, and that hopefully gives you 753. But you should be able to do it both ways. If I said that the actual DPM was 753 and the measured count rate was 640, what's the efficiency?
85.
So,
640 over 7.
yeah, basically 640 divided by 753. Okay. So be aware of how to do that. Okay.
Did you say that the DPM is always higher than the CPM?
Yes. And why is that? How come if the CPM is always lower than the DPM?
Because you don't have 100% efficiency. There's no 100% efficiency detector.
Yeah, remember that not all the radiation your detector measures gets recorded. You guys would be really surprised, you know, the efficiency of like a gamma camera detector is on the order of about like 1%. Because, you know, you got radiation going in 360 directions, or 360 degrees, so. And again, on this one here, we talked a little bit about that in the patient care. Okay, so you should know all of the different aspects of body mechanics. You know, base of support, all that kind of stuff, and you know, pushing, pulling, things like that. Okay? So the thing they're looking for here is the incorrect one is having the patient's center of gravity away from your center of gravity. So remember, you want it as close as possible to you. Y'all got 100% on that one, right? If you don't, you're going to hurt your back. Trust me on that. Okay. Okay, the first step that should be performed if the patient goes into cardiac arrest is
Call for help. Hit the code blue button.
okay. Well, honestly, the correct procedure. No.
Call for help.
Okay. First thing is to check for responsiveness. So if that was available, that would be the first thing to do. As soon as you determine they're unresponsive, then you call for help. Okay. And then now, rather than opening the airway, you're going to check the carotid pulse for 10 seconds and determine if you need to do. Yeah, remember it's CAB now, so it's circulation, airway, and breathing. So you're going to do chest compressions. That's more important than, or at least that's what they're saying. I mean, in all the years I've been teaching CPR, which goes back to like the 70s, I mean, I used to actually teach back pressure arm lift. Put the patient down on the ground and you push on their back and lift their arms up.
But if the patient's in the room with you and they cold it and you try to give them breath, you're gonna get the hepatitis A if you don't have.
Well, that's why you're supposed to know where your ambu bag is. There is no reason why anybody should be having to do mouth to mouth. We you know, when I'm out on patrol, I have a portable mask. But when you're in the hospital, they don't have those. They typically have the ambu bag, and you hook that up to oxygen. You know, 15 liters or whatever that thing will go up to. You just, I mean, if you can inflate them up like a blimp, that's, you know, all more power to you. They're floating off the table. That's great. You know. But the thing is that you want to make sure you're getting them a lot of oxygen. So even if they have COPD, you still give them, you know, 15 liters. It's just a patient who's, you know, a normal outpatient that comes in who has COPD or an inpatient, you don't give them more than 3 liters. Okay, this is a good one. If tracer concentration is visualized in the skeleton, kidneys, liver on a bone image, what is the most likely explanation? Okay, remember that aluminum causes it to mix with the stannous chloride in the kit, and it forms tin colloid. Tin colloid is just like sulfur colloid. It goes to any of the RE cells. So it's picked up by the bone marrow, the liver, the spleen, and so that's what the problem is. Okay? And if you have too much aluminum when you're making sulfur colloid, then you get these great big globules of sulfur colloid that wind up going to, where do you think they would go?
Bone marrow.
Remember, they're great big.
Spleen.
No, that's where they would normally go. Where do great big particles get trapped?
Lung.
Lungs, yeah. So if you do a sulfur colloid scan and you see lung activity, you probably either didn't shake the syringe when you injected it, it's been sitting there and the particles have flocculated, or you have too much aluminum in the eluate, and so it's causing the sulfur colloid to bunch up. Okay, which of the following is consistent with chromatography results of HDP that have 85% radiochemical purity? Okay, again, you should be able to look at a whole body image and determine which radionuclide it is. Okay, so if you see bone marrow and spleen activity, which
Silver colloid.
Well, bone marrow and spleen, not bone marrow, liver, and spleen. It's probably a WBC scan, because normally you're going to see a lot of more activity in the spleen on a WBC than you will sulfur colloid. Okay, but on this one here, okay, remember any of our technetium products that don't label properly, and when we say radiochemical purity, what are we actually measuring? What test would you do to determine this? Okay, it's chromatography, and here you're just trying to make sure that your radiopharmaceutical is in the proper valence. Okay? So, normally if you have technesium, when it's not tagged anything, has what type of a valence?
Plus 3, plus 4.
Well,
Or
that's,
plus 7.
okay, well that's, yeah, or if it's pertechnetate, then it's going to be -1. Okay? Okay, next one here. Again, they're not going to give you a whole lot of information, but here you have the molybdenum is 10 microcuries and the technetium 416 millicuries. You do this at 6 o'clock in the morning. Okay, so basically on this one here, you're going to take 10 microcuries and divide it by 416 to calculate the microcuries of molybdenum per millicuries of technesium. Okay, what's the allowable limit?
0.15.
Okay, so 0.15 to 1, right? Okay, so sometimes they may have you calculate it out, but in this case here they're saying, okay, if we waited an hour, no, I'm sorry, we decayed it down to 11 hours later, it's almost 2 half-lives. The molybdenum's not going to change too much in 12 hours. But technetium, okay, you're down to about 100 millicuries right now. So, make sure that it doesn't exceed that 0.15 microcuries, okay? Everyone okay on that? Next one here. Okay, according to the NRC, which sign should be posted on the door of the radiopharmacy, which have been measured to be 12 MR per hour? Y'all agree with that? Yeah, remember that if it had radioactive material, we wouldn't have a radiation reading. It wouldn't be anything in MR per hour. It would have to be an amount of activity in there to be radioactive materials. But a radiation area means that it's greater than 5 MR per hour, but less than 99 MR per hour. So it's somewhere between 5 and 99 MR per hour. What's a high radiation area?
Greater than 200.
100. It's more than 100 MR per hour up to 500 R per hour. Then it's a high radiation area. Then anything over 500 R per hour is going to be this one. Okay? So, did you need a copy of the test? Or?
I got one at home.
Oh,
Yeah, I left it at home.
thank God the dog didn't need it. Okay. Okay, which of the following is false about an I-131 treatment? Okay. Obviously, you cannot have people in the room, right? And the other thing is, why would you give somebody 75 millicuries and put them in radiation isolation? What do we normally give I-131 for?
Graves, hyperthyroid, cancer.
Well, in this amount here, remember with Graves,
Cancer. Graves is less, like 15.
yeah, sometimes you may have a autonomous nodule, sometimes you may have a multinodular toxic goiter. Usually the maximum you would give a patient in those conditions would be about 30. Okay, hyperthyroidism, Graves, is typically somewhere between 4 and 10 millicuries. So this is a patient that may have, well, probably definitely has thyroid cancer. And normally we give about 100 millicuries to a patient who's being treated with thyroid cancer. Great. Can go up as high as maybe 200. Now, if there's METs, then they may give 150. If there's METs to the bone, they may give 200. Okay, I know some places have given more than that. But there are situations where you deliberately give the patient less than the 100 millicuries. Anybody give me an idea which type of condition that would be? Huh?
Hyperthyroid.
Some kind of thyroid seeding that hasn't spread.
Well, now for ablation, we typically give 30 millicuries. So if I have thyroid cancer, they normally cut out the bad side,
So you
and then we kill the rest of it with 30 millicuries of I-131. Okay, that's called ablation. Okay, because you're basically killing normal tissue. You're not killing pathologic tissue. Okay? So after that's dead, then we start treating the cancer. Okay, but we can't do anything until we kill the thyroid tissue. But instead of giving 100 millicuries, typically the dose is reduced when the patient has poor renal function. Okay? Remember that when I give iodine to a patient, 100% of it gets absorbed by the intestines. Roughly 60% of it gets excreted out through the urine. 10% stays in circulation, and usually 30 to 40% of it goes to whatever thyroid tissue is left. But if the patient has poor renal function, then you would reduce the dose. Otherwise, what would happen if I didn't reduce the dose?
Then you destroy the kidney and
Well,
bladder.
not only, the kidneys aren't functioning that well. So if the kidneys
Bladder.
aren't functioning that well, that's no longer my what we call critical organ. So if it's not being filtered out, it would stay in the bloodstream. Okay, so what would it be going through that would be affected in the bloodstream?
Liver, lungs.
Well, those are pretty tough. How about bone marrow? That's what our main concern is. If the patient has poor renal function, we don't want to kill the bone marrow. And in fact, some hospitals, and I don't know if you guys do this routinely, but before they treat a patient with I-131, they do a complete blood count, look at the platelets, look at the WBCs. You guys do that? I used to do a chest X-ray, white blood cell count, TSH, all that kind of good stuff before we treat the patients. Okay, next one. Federal regulations, which is true regarding the package containing multiple doses of technesium radiopharmaceuticals. Okay. Remember that ideally what you're supposed to do first is visually inspect the package, make sure there's no damage or stains. If that choice isn't up here, then okay, the package must be opened with no special precautions. That's definitely wrong. The package must be set aside for as long as possible to allow decay. Visual inspection must be performed. If that's acceptable, no other inspections or surveys are needed. Okay, that's obviously not correct. That just means you can open it safely after you monitor it, right? So external surfaces must be promptly monitored by the licensee for contamination levels. Now remember, you have to keep in mind what type of labeling you have on the package, and when you measure it, it should be within those limits. It should never be above what at the surface.
What is it, 0.5?
Yeah, it should never be higher than 200 mR per hour, regardless of what's in there. Okay, so it has to be adequately shielded to make sure that it's always reading less than 200 mR at the surface, and how much at 1 meter? 10 mR. Okay, very good. Okay, now we haven't talked about hematology yet, but I am going to be getting you some stuff on hematology. This is an important thing to remember because when we're labeling white blood cells, or if we do ever label red blood cells, I mean, normally it's not a big problem for red blood cells, but you may have to take a look at that to see if the patient has enough cells to tag. So the hematocrit is basically, well, let's see, Mr. Singh, what is the hematocrit?
Is that belongs to the red blood cells? That's where I'm not too sure, but
Okay, Ashley, help him out. What's the hematocrit? Who knows down here? Anybody? Okay, Monica?
It's the ratio from plasma and RBC.
Yeah. Basically, it's the ratio of your cells to the plasma. Okay. Normally, what you do is you take a sample of blood, you put it in a centrifuge and spin it down. I don't know of anybody that just lets it sit. But basically, typically it's about, somewhere between 45 and 55%. Typically, that's the percentage of your packed cells, your red blood cells. So in this case here, if you're doing a calculation, so basically it's going to be your cells, the 2658 over the plasma plus the cells. Okay. So might want to write that one down because that's usually a test or two that you might see. They'll give you at least one or two questions on.
So it's RBC over RBC plus plasma?
Yeah, it's RBCs divided by RBCs plus plasma.
What's the TBV?
This is the total blood volume.
Oh,
Yeah, so the total blood volume is actually this.
That's what we're having.
This is the red cell volume and this is the plasma volume here. It's kind of like when we were calculating chromatography. It's the amount at the,
Amount of travel.
Yeah, amount-
Divided by the
yeah, both, yeah, the origin and the solvent, not the solvent, but the,
Solid, right?
yeah.
Far out.
Okay. But again, I'm going to send you some stuff on hematology a little bit later. I don't really concentrate on that because there's not very many questions on it anymore. And the thing is, I don't know anybody that does it except Loma Linda. Loma Linda still does it once. Yeah. Normally, the only reason why we do this is if you have burn victims or if you have a patient who you're trying to determine if they truly have polycythemia. If you have polycythemia, then this is going to be abnormal. The hematocrit can change depending upon how much water there is in the body. So if you're dehydrated, this is going to be artificially high. Yeah. And if you have diabetes insipidus, where you don't have the pituitary gland regulating ADH anymore, you're going to be drinking a lot of water, so your blood's going to be very dilute. So anyway, then the next one down here, okay, so according to the NRC regulations, the external dose in an unrestricted area must be below, and remember we said 2 MR per hour at all locations. You could also put down 100 MR in 7 days. Okay, I don't know if that's going to be in there or not, or less than 0.5 gram per year.
How much in 7 days?
100 MR. Okay. This is always a good question. How long must your occupational dose records be maintained? And it's basically as long as you have a license. So if one of you guys gets a high radiation dose, you immediately close your place, send the license back to the state. After you die in the funeral, then you come back and restart up again. Okay? Just FYI. Okay? You don't like that one? Okay, your clothing becomes contaminated. What should you do? Yeah, remove the clothing and let it decay to background. Hopefully you have a change of clothes.
there's always scrub in the hospital.
Yeah. Well, that's the other thing, because I've gone up to the OR and there's no scrubs. I don't know if you guys were around during the days when it was fashionable to be wearing scrubs as you walk around town. So people were stealing scrubs out of the OR, and they said you can't do that anymore. So you want to make sure that you do have, especially ones that fit. Those are the two criteria. How long would this be approximately? Yeah.
10 half-life.
10 half-lives, so how long is that?
If you have I-131, that's 8 days, so at least 80 something days.
Okay, about 80 days. Yes, sir. Yes, ma'am.
Oh,
Okay.
yes.
Which statement about PET tomography is false? Okay. Why is this statement false? PET is a superior modality for the assessment of anatomical change. Right, it's physiology, it's not anatomy. Okay, most of our other stuff is anatomy, or either that or it's a combination of anatomy and physiology, but with PET, and I'm assuming that they're talking about PET FDG because that is mainly the only one that you're going to be dealing with. They're not going to be asking you a whole lot of questions about any of the other PET pharmaceuticals, because they're not, unless you have a cyclotron and you're doing research and all this other stuff, you're not going to see it. Now, if you take the PET exam, the NMTCB PET exam, then yeah, they'll ask you everything. They'll ask you the names of the photons. You know, what are the names of the photons coming out of the, like Fred, George, Barney? Okay. Next one down here. There's 375 millicuries of technesium present on the column of a generator. Has 85% efficiency. What is the amount that you can expect from that generator? Yeah, so 375 times 0.85. How come we don't get it all out?
Because some of it gets
Yeah, stick. Remember that when you have radiation ionizing things, electrons are released. And those electrons will combine with the technesium that's in there and change the valence. Once that valence is changed, then it will bind to whatever's handy or close by, which in this case happens to be the column, so it does not get washed off. Okay? Some of it does wind up getting washed off, and then remember we have two types of technesium that you need to check for. Yeah, we have the bound, then we have the reduced, then we have the free, right? Okay. So what you're measuring here is the amount of actually bound technesium, so that's where most of it gets lost. Okay. What is the normal range of efficiency for a technesium generator?
90.
What is it?
95 to 85.
A little bit higher than that. Usually it's about 85 to 95%. So 85 is kind of the low end of it. Again, the bad thing is that because we don't have generators in the hospitals anymore, you guys don't get to see this. However, it's still on your board exam, so the NMTCB and ARRT don't care. Okay, which of the following would be used to perform a sphincter of Odai study? And what are we looking for here?
That's a high one.
Acute versus.
Okay, acute versus chronic cholecystitis. So, and again, they're going to ask it just like this. Okay, which agent would you use for a sphincter of Odai study? So, what does morphine do?
Contraction. Holding.
Okay, it contracts the sphincter of Odai, and what is that going to do?
Causes increased pressure in the ducts, allowing the gallbladder to fill.
Okay, yeah. Literally, it forces technesium into the gallbladder. Do you all remember what all these things? What is mercantile used for?
That's Mac 3, that's renal.
It's Mag 3. Yeah. Please, please, please. They're going to give you the generic name for it. So they're not going to call it Mag 3. They're going to call it mercantile.
So what's the discipline?
Huh?
Discipline.
Both of those. Disophenin is another type of hepatobiliary agent. Anything that has phenin on the end of it is a gallbladder agent. So mebrofenin, lidofenin. Yeah, you got most of the time we use mebrofenin. Okay, disophenin, but I mean there's like three phenins out there. Yeah, but if it says phenin on it, just know that it's a hepatobiliary imaging agent. Cholecystokinin. When would you use cholecystokinin? Okay, CCK. What would you use that for?
That's only when you see the gallbladder.
Okay, you have a gallbladder that fills up and you want to empty it, right?
Yep.
Hi, Margaret.
Good morning.
Okay. Okay, let's go down here. Okay, what is the minimum number of millicuries needed at 8 a.m. to deliver 3 20 millicurie doses that are to be injected at 10 a.m. or that are be injected from 8:30 to 10 a.m.
So that's, so you have 8 an hour.
Okay, well, you remember you have 20 millicuries. This is why it's a nice idea to remember these decay factors. Okay, so for the first dose, it's 30 minutes after the calculation time, right? So 20 millicuries divided by 0.944. Okay, so that accounts for the decay on that. This is actually the more accurate way to do this determination. In Ann Steve's, they would tell you that, okay, you've got from, what was it, 8 to 12 or 8 to 1?
1:30.
Okay, yeah, so from 8:30 to 1:30, that's about, what, 5 hours? So if you get the decay factor for 5 hours and divide that into 60 millicuries, because you have 3 doses, right? So you'd have 60 millicuries divided by the decay factor for 5 hours. That's another way to give you an average idea of how much activity you need, but it's not as accurate. Okay, so the accurate way is you calculate it for each dose. Margaret, do you need to talk to them?
I didn't.
Huh? It's going to hang this?
I didn't want to, well, I just want to talk to them a little bit, tell them something.
Oh, why don't we take a short break and then I'll have Margaret talk to you and then